Good afternoon, everyone. I am Perlan J.F. Velasco, and together with my co-reporter, we will be reporting the topic 17, which is the challenges in assessment. So, I will discuss about challenges in assessment, the resistance and inability to provide information, and evaluating children. Next is cultural and ethnic diversity and assessment, the cultural bias in assessment, how do such biases come about, and these strategies for avoiding cultural bias for assessment. Let's start with challenges in assessment. Some challenges that arise in assessing people's problems include people's inability to provide information or resistance to providing information. In addition, special challenges arise when evaluating children and people from cultures different from that of the assessor. So, under of this is resistance and inability to provide information. It happens when a specific person resists or declines to give a specific or important information which is valuable for the specific assessment. And it is one of the biggest problem of the psychologists because they cannot get and give the accurate result. A person's reluctance to divulge information can be one of the biggest obstacles to getting accurate information from them. When an adolescent is compelled to see a psychologist because his parents are worried about his behavior, for instance, the person may not want to be evaluated or treated in those situations. The adolescent might be reluctant to divulge any details. Resistance can be a major issue because a lot of the data a doctor needs must come directly from the person being assessed. Even when a person is not completely averse to being evaluated, they may be highly selective in the information they provide, biased in how they present the information, or even outright dishonest with the assessor if they have a strong interest in the assessment's outcome. There are times that the client will just choose or filter the information that they will going to share. It's either they are ashamed of it or it has a negative impact on his or her side. These issues frequently occur when assessments are conducted as part of a legal proceeding, such as when divorcing parents are vying for custody of their children. Each parent will want to present him or herself in the best light and also may negatively bias his or her reports on the other parent when speaking to psychologists who have been appointed to assess each parent's fitness for custody of the children. Let's move on to evaluating children. Anyone who has tried to have a conversation with a distressed child about why he or she misbehaved has some sense of how difficult it can be to engage a child in a discussion about emotions or behaviors. We can see in here if how the child dismissed the conversation between him and her mother. By that action alone, the child is already resisting to given information. Even when a child talks readily, his or her understanding of the causes of his or her behaviors or emotions may not be very well developed. Children, particularly preschool-age children, cannot describe their feelings or associated events as easily as adults can. As an adult, we can feel pain emotionally and we can elaborate why do we feel that way, or we can assess the causes of the pain or the reason why we feel that way. Young children may not be able to distinguish between different emotions, frequently just stating that they feel bad. For instance, children may talk about aches and pains when upset rather than the emotional agony they are experiencing. So it is even harder to assess or evaluate children because they can't assess the reason or the causes of their feelings or emotions in the first place. Alternatively, a young child may merely exhibit nonverbal signs of distress, such as a sorrowful expression, withdrawal, or violent conduct. Due to issues with children's ability to self-report emotional and behavioral issues, therapists and researchers must now rely on information about children's functioning from other sources, typically adults in the children's lives. Parents are frequently the first people to learn about how a child is doing. When a child is brought in for therapy, a clinician may speak with the parents and inquire about changes in the child's behavior and associated life events. Parents may be asked to respond to questionnaires analyzing their children's conduct in various contexts by a researcher looking at how youngsters function. So instead of asking the children about what really happened, or instead of pushing them to give a detailed information, therapists ask their parents instead, since they are the one who knows about the happenings next to the children themselves. As a parents, they are more likely the one with their children all the time, because parents typically spend more time with their child than any other person does. They potentially have the most complete information about the child's functioning and a sense of how the child's behavior has or has not changed over time. Unfortunately, however, parents are not always accurate in their assessments of their children's functioning. One study found that parents and children disagreed as to what problems had brought the child to a psychiatric clinic in 63% of cases. Parents' perceptions of their children's well-being can be influenced by their own symptoms of psychopathology and their expectations for the children's behavior. Indeed, sometimes parents take the children for assessment and treatment of psychological problems as a way of seeking treatment for themselves. Parents also may be the source of a child's psychological problems and, as a result, may be unwilling to acknowledge or seek help for that child's problems. They are maybe ashamed that the therapist may know that they are one or the main reason why thus their son has a psychological problem. The most extreme example is parents who are physically or sexually abusive. Such parents are unlikely to acknowledge the psychological or physical harm they are causing the child or to seek treatment for the child. Those parents may be in denial or don't have any care at all on what will be the possible effects or results of their action into their child. Different cultural norms for children's behavior influence parents' expectations for their kids and their willingness to accept their deviant behavior. For instance, Jamaican parents seem to be more understanding of atypical behaviors in children, such as violent conduct as well as behavior showing shyness and restraint, than American parents. When it comes to the right moment to take a child to a clinician, Jamaican parents have a higher threshold than American parents. Teachers also give details about how the kids are doing. Teachers and other members of the school staff, such as coaches and guidance counselors, are frequently the first to identify a child's problem and launch an intervention to address it. However, assessments made by other adults, such as parents and qualified clinicians, differ frequently from those made by teachers of children. Such discrepancies may occur as a result of these other adults giving the children inaccurate assessments while the teachers give accurate assessments. The differences could also result from how differently children behave in various contexts. A child may be well-behaved, quiet, and reserved at home, yet that same youngster may be impetuous, easily irritated, and easily distracted at school. Let's proceed to cultural and ethnic diversity and assessment. Studies of the influences of culture and ethnicity on psychopathology and its assessment have proliferated in recent years. It is critical to keep in mind that there are typically more differences within cultural and ethnic groups than there are between them. Remembering this important point can help avoid the dangers of stereotyping members of a culture. In this section, we discuss problems of cultural bias and what we can be done about them. Assessment must take the person's cultural background into account. Believing in possession by spirits is common in some cultures and thus should not always be taken to mean that the believer is psychotic. Next is culture bias in assessment. When test questionnaires evaluate information or experiences that are unique to a particular culture, cultural bias occurs in the testing materials. As opposed to the child's culture, the examiner's cultural prejudice results from assumptions based on his or her experiences and background. The idea that a measure created for one culture or ethnic group may not be as trustworthy and valid with a different culture or ethnic group is referred to as the cultural bias in assessment issue. Some American-developed examinations have been effectively translated into other languages and applied to various cultures. For instance, The WAIS has been offered in Spanish for more than 40 years and can be helpful in evaluating intellectual functioning in individuals from Hispanic or Latino cultures. The MMPI-2 has also been translated into more than 20 different languages. Simply translating words into a different language, however, does not ensure that the meaning of those words will be the same across different cultures. Several steps in the translation process, including working with multiple translators, back translating, and testing with multiple native speakers, can help to ensure that the test is similar in different languages. This approach has been successful in achieving equivalence across different cultures and ethnic groups for some instruments such as the MMPI-2. Even with the MMPI-2, however, there are cultural differences that are not likely attributable to differences in psychopathology. For example, among Asian Americans who are not heavily assimilated into American culture, scores on most MMPI-2 scales are higher than those of Caucasians. This is unlikely to reflect truly higher emotional disturbance among Asians. For children, the latest version of the WISC has not only been translated into Spanish, it also has a complete set of norms for Spanish-speaking children in the United States, and the items have been designed explicitly to minimize cultural bias. Despite these efforts, the field has a ways to go in reducing cultural and ethnic bias in clinical assessment. These cultural assumptions or biases may cause clinicians to over or underestimate psychological problems in members for other cultures. Please note that the MMPI-2 is a self-report inventory with 567 true or false questions about yourself. Your answers help mental health professionals determine whether you have symptoms of a mental illness or personality disorder. Some questions are designed to reveal how you feel about taking the test. So how do such biases come about? Cultural factors may affect assessment in various ways. Language differences, differing religious and spiritual beliefs, the alienation or timidity of members of ethnic groups when being assessed by clinicians of the Euro-American culture. All these factors can play a role. For example, clinicians who encounter clients claiming to be surrounded by spirits might view this belief as a sign of schizophrenia. Yet in Puerto Rican cultures, such a belief is common. Therefore, believing that one is surrounded by spirits should probably not be taken as a sign of schizophrenia in a Puerto Rican person. Cultural and ethnic differences in psychopathology must be examined more closely. Unfortunately, the cultural and ethnic biases that can creep into clinical assessment do not necessarily yield to efforts to compensate for them. There is no simple answer. DSM-4-TR's inclusion of cultural factors in the discussion of every category of disorder may well sensitize clinicians to the issue, a necessary first step. When practitioners were surveyed, they overwhelmingly reported taking culture into account in their clinical work. So it appears that the problem, if not the solution, is clearly in focus. So let's proceed to my last topic, which is strategies for avoiding cultural bias for assessment. Clinicians can and do use various methods to minimize the negative effects of cultural biases when assessing patients. Perhaps the place to begin is with graduate training programs. In 2002, Lopez has noted three important issues that should be taught to graduate students in clinical psychology programs. First, students must learn about basic issues in assessment, such as reliability and validity. Second, students must become informed about the specific ways in which culture or ethnicity may impact assessment rather than relying on more global stereotypes about a particular cultural or ethnic group. Third, students must consider that culture or ethnicity may not impact assessment in every individual case. Assessment procedures can also be modified to ensure that the person truly understands the requirements of the task. For example, suppose that a Native American child performed poorly on a test measuring psychomotor speed. The examiner's hunch is that the child did not understand the importance of working quickly and was overly concerned with accuracy instead. The test could be administered again after a more thorough explanation of the importance of working quickly without worrying about mistakes. If the child's performance improves, the examiner has gained an important understanding of the child's test-taking strategy and avoids diagnosing psychomotor speed deficits. The examiner may need to put out more effort to build a rapport with the client when they are from various ethnic backgrounds in order to get the best performance possible. One of the authors, for instance, was unable to elicit a verbal answer from a timid preschool Hispanic child during testing. The boy was overheard conversing animatedly and intelligently with his mother in the waiting area, which led to the conclusion that their test results did not accurately reflect the child's linguistic abilities. Advanced verbal skills were seen during testing that was repeated in the child's home with his mother present. Clinicians are urged to be especially cautious when taking inferences from patients with varied cultural and ethnic origins in order to reduce such issues. Instead, they are instructed to form hypotheses regarding how culture may affect a certain client, consider competing ideas, and then test those hypotheses. This would be the end of my report.